thing. So that's what most docs will do. They'll give it first thing without even thinking about sending these people to OT or PT. But we can have quite a large effect, I think, on some of these patients. Cueing is one of the things we look at. Instructional cues: think big, act big, do everything as loud and as hard and as big as they possibly can. Auditory cueing, you can give them a rhythm, and if they'll step in time to it. And like I mentioned, I've often used an auditory metronome. You can go to Radio Shack and buy a little auditory metronome. It can go beep, 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 and you turn it, the frequency up, stick it in an earbud in their ear, and away they go. Beep, 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 beep. Walking in time to these auditory cues. Michael throws a lot of work in, last author there, in Colorado, and he gave them embedded tones in their own favourite music, and they'd do their ADL to this music, beep, 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 and he found that worked. Visual cueing, we mentioned that very briefly. Somebody asked me that paper, that's where it was published in Physical Therapy Journal 2006, a while ago now. This is this lady who came into us, an experiment I was doing, and this is a pre-baseline gait. Put the cues, you measure step length, increase the step length by 10%. So these duct tape, masking tape lines were on the floor, which were 10% greater than her baseline step length, and lo and behold, she could step right over them instantly. And away she went doing this for 5 treatment sessions. Then we increased the length to 120% of the step length, and she walked over those for 7 treatment sessions over a month. Okay, and then we came back, took the cues away, tracked her gait for a month. This is 1 month after we took the cues away. Zooming along she was. No change in meds or anything. Question?
What was
the cutaneous cues, if they're frozen, you kind of push them, get them off one foot like this, lock them, and then they can start walking like this. Okay? Not as good. I think visual cueing is the best way to go with these patients, definitely. I mean, now they've done this stuff, since this research has come out, I talk a lot about it in motor control, but you can buy these glasses now, little computer, gait aid, it's called. You Google it, put gait aid, and they put these heads-up glasses, and you can see a checkerboard pattern in your visual array all the time. And they'll walk as treatment with these glasses on, and they see checkerboard floor pattern, like tile, and they'll treat them, walk with these glasses on during treatment, and that's been shown to effectively as a carryover improve their gait. Oh, this is showing that pre and post. And this lady, I spoke to a year later. She said it worked for a year at least. Improved gait. So I do it with everybody. I get cues on it in their carpet, in their hallway, in their kitchen, whatever it is. The biggest length of place, biggest run you can find in their house. Stick cues down. Measure step length, increase the step length by 10-15%, whatever.
So then if you did it again, would you maybe another year?
I could, yes. You could have top-up sessions where I did it with this lady, but yeah, that's quite feasible. I've done that in the past, yeah. But people, once I tell them the technique, they do it themselves. This one guy was walking, down in Bangor, he was walking 3 times a day up and down his cues in his living room, and within a couple of weeks he was walking on the park, and walking around like 9 months, something like that. So it is quite effective. Why give them dopamine when you can do this first? Hold off the dopamine until they really desperately need it. What else? Anything else about Parkinson's disease? Why can't you give them dopamine? Pure dopamine. It doesn't cross the blood-brain barrier. You have to give them levodopa or L-dopa. You combine that with carbidopa stops the L-dopamine utilized elsewhere in the body, allows it to get to the brain. You have a higher concentration of dopamine in the brain. Okay? So this is not an exam. Some other diseases that kind of like to affect the basal ganglia preferentially. Wilson's disease, named after an English bloke, Samuel Wilson, the doctor who first sort of wrote about this disease in 1912. Very rare, but I've seen somebody with this, and interestingly, after I spoke about it in class, a student of ours saw somebody with it. It wasn't diagnosed. So this is basically, Wilson's disease is a problem with copper metabolism. Okay, you have retained copper. It's a metabolic disorder, and you inherit it. So you find copper deposits in the globus pallidus and the putamen. In parts of the basal ganglia, you find little copper deposits, basically, which screws them up. So the basal ganglia aren't functioning correctly, and therefore you get very Parkinson's-like symptoms. Very easily confused with Parkinson's disease. So I had one of these patients who sent to me, who was home health, they wanted me to help with his gait, and I looked at him, and there was something didn't feel right to me. It didn't look perfectly like Parkinson's disease, and I looked in his eyes, and I saw that. Kaiser Fleischer rings. Those are two different people. You can see that orange copper-like colour right around the edge of the iris here, and this one on here, two different people. Okay, and I looked at that and I said, this is not Parkinson's disease, he needs to go back, and I recommended that his PA, I mean his PCP, his primary care physician, you know, his family doctor, was prescribing dopamine, and I said, no, I think it's probably Wilson's disease, and he went back and learned what it was. It did some blood work, and you can treat this quite easily. Parkinson's you can treat, but you're not going to get rid of it, right? It's there. You can help out. This stuff, Wilson's disease, you can use penicillamine, for example, is a drug you give them, which causes chelation of the copper. Do you know what I mean by that? From chemistry? Did you talk about chelation any now? This drug basically binds with ligand bonds to the copper. It basically circulates in the blood, in essence, picks up the copper and binds to it, and you excrete it in your urine. So it basically strips the copper out of your blood to a, you know, very, very basic level. And the symptoms will go away if you do this. The person can be cured, as it were, if you get this chelation within the bloodstream and get that copper out of them. And 3 months after we went back to the doctor and they started him on this, he was fit, he was walking, his Parkinson's symptoms disappeared. But after we've been treating him for years, Parkinson's disease, and we've had no effect really. So I was lucky to find that in this one guy. It takes a while to get all the copper out. A few months, maybe 6 months later, you should have got, you know, most of it stripped. So the patient often will have these symptoms of Parkinson's disease for 6 months after they start taking this drug. Gradually goes away. So in those 6 months, again, you're treating the OT and PT, you're treating those symptoms, you're helping with his balance and his gait, whatever, as this copper is gradually stripped out of his system. So this is rare, and it's I don't know, it's about 1 or 2 per 100,000 people get this. So it's quite rare, but saying that, a student last year who graduated emailed me and said, I found a bloke with Wilson's disease in Brewer. He was diagnosed with Parkinson's. I looked in his eyes and you saw this thing, and he picked it up. And he went, this patient was sent, and he's been fixed because of this, looking at this bloke's eyes. You could treat it for Parkinson's disease. You think it looks very similar to Parkinson's disease. Maybe the one thing often you'll find are more psychiatric issues in Wilson's disease than Parkinson's disease. There's other issues going on that you might not pick up, but they're there typically. They're more anxious, they're more incidents of psychosis with Wilson's disease, and depression. But then again, Parkinson's patients may present with depression, anxiety, but they're more prevalent in this Wilson's disease type issue. So look out for that one. And I've actually seen a question on the boards about Wilson's disease. It's one of those little tricky questions to go forward with because it's so rare, but you should be aware of looking out for this. Okay? So there's various careers you can get, and we mentioned this previously, I think. Huntington's career is a hereditary disorder where you get defects in parts of the basal ganglia and often the cerebral cortex. you get a defect in the basal ganglia, particularly the corpus striatum. And it's hereditary. You can trace people back, long way back through history who've had Huntington's disease. Some of the witch trials in Salem, Massachusetts, might have been due to people with Huntington's disease. And you can trace those people in New England who've got Huntington's disease. Many of them you can trace back to 3 families in a little town in England. Sorry, what's it called now in town? Burries, B-U-R-R-E-S. If you look at the lineage of these folk, many of the people in New England basically have come from, this little town in England where these 3 families had Huntington's disease, and it came across in the boat with them in the 1630s that they found, this sort of cell of Huntington's disease in Salem, Massachusetts. So you get Korea. So let's look at. I'll show you before. No, this is an example of a Korea. Dance-like movements. Compare that to acetosis, which is also a symptom you'll see with patients with basal ganglia disease. It's a symptom, it's not a disease. Often due to corpus striatal problems, disease in the corpus striatal for various different reasons. Often you'll find patients with cerebral palsy. We talk about acetoid CP. The dominant symptom of kids who have this problem is called, will be called acetoid CP. So this is acetosis. Notice the difference between this and your Korea. Come on. That writhing, twisting kind of convolution of the hand. So your children will be presenting that as they're trying to walk, the hands are writhing, facial twitches, grimaces sometimes. That's acetosis.
Do they get that when they're trying to move their hand, or does it just do that?
It just does that, yeah. Yeah, it can happen while they're trying to control the limb as well. It's not just erecting, not really intention, it's sort of both really, it can be. Although some patients display more in kind of... another little symptom, an issue, not a symptom, hemibolism, half ballistic it basically means. So one limb, typically, or one side of the body will display wild, flailing movements, forceful twitches of the arms. This is very characteristic of a subthalamic nucleus issue, which is part of the basal ganglia in many texts. Subthalamic nucleus, remember we talked about that as being part of the basal ganglia. Damage to the subthalamic nucleus, you'll often see this hemibolism, and this is a patient with that. This is purely involuntary. You can't stop it.
Hurting. Yeah, like this movement is what it is. Does it just like tense up when it's doing that? Yeah, it's like stuck in the position. And then it like doesn't like, okay, then it's like, let's go and
Totally perfectly fine, obviously.
Okay,
She's trying to conduct the orchestra, try and get control of it. And finally, another lady. It comes and goes.
Put your arms out in front of you.
Some people it's takes a long time.
And time with the left hand.
Hard to live with that, eh?
Go back again.
Left arm. Okay, so that damage the subthalamic nucleus. You see hemiball is a wild, flailing, uncontrollable movement of one limb, typically.
How do you get that?
Unknown idiopathic, typically, to the subthalamic nucleus. You don't know, it generates for some unknown reason. Okay, enough of motor pathways. Let's look at our strokes. Okay, so stroke, I think, is it like a third leading cause of death in America? Behind cancer and heart attacks, I think. I think it's the third leading cause. You're going to see many patients, of course, with stroke, cerebral vascular accidents. Very good to remember, the brain itself is about 2.5% of your body weight, but it uses 25% of the oxygen. So it needs oxygen constantly. It needs a continual supply of oxygen because, of course, it cannot, neural tissue cannot function anaerobically. Not like your muscles. Okay? If you deprive neural tissue of oxygen, very shortly it will die. Particularly the higher level parts of the brain, like the cerebral cortex, they'll be permanently damaged if they don't get blood continually. Your deeper areas, your brain stem can handle a little bit longer. So you can lose all cognitive functions, but you basically tick over your vegetative function with the basic brain stem issues. You've got about 7 cc's of blood, of O2 in your blood, in your brain at any given time, which will last you about 10, 15, maximum 20 seconds. So if you deprive the brain of blood flow for about 15 odd seconds, the person will go unconscious. This is how you choke people. In wrestling, where you take a chokehold, deprive close down the arteries, no blood to the brain, they pass out. So you've only got a limited supply of oxygen circulating in the blood, so you need this continual supply to maintain consciousness. 2 pairs of arteries do that for us. There's 2 pairs of arteries supply our oxygen to our brain. They are, of course, the internal carotids and the vertebral arteries. Okay? Typically, not everybody has 2 vertebral arteries. The majority or more blood flows through the carotids than the vertebral arteries, but a good chunk flows through the vertebral arteries. We have a right and left vertebral artery. Okay, they come off the brachiocephalic trunk down here. So those arteries come off the brachiocephalic trunk. Okay, which leads into the subclavian. So your brachiocephalic trunk comes out of the heart over the clavicle here, and it turns into what's known as the subclavian artery. Now, right where they that name changes between the brachiocephalic and subclavian, you'll see this vertebral artery coming off. Some texts will say it comes off the brachiocephalic, some texts will say it comes off the subclavian. Probably most will say subclavian, whatever. So this is the one here that goes up through those transverse foramen of the cervical vertebrae. Remember those cervical vertebrae, there are holes in them on the transverse processes. Okay? It usually does not go through the last one, the bottom one, C7. But it goes through C6, 5, 4, 3, etc., up the spine there. Okay? And it can get pinched. So, you're doing your vertebral artery test. Remember your vertebral artery test? Twist your head and extend backwards. Okay, you are now pinching off you're testing the patency of which artery doing this. The right one. Okay, doing this, you're clogging, you're squeezing, you're stretching out the left one, closing that one down. Fine, no big deal, because I've got my right one working. Okay? But if my right one has got an arterial dissection in it, or some plaque build-up and it's, you know, not there, it's clogged, then you'll start seeing those vertebral artery symptoms, which would be what? Nauseous, sweating, nystagmus, things like this. You hold the patient in that position, watch out for those nystagmus. You're going to be very careful with these patients if you're going to be doing any kind of cervical treatment on these patients. If they've got this. Some of us might, I mean, occasionally, if you try it later, have you all tried the vertebral artery test? Some people will have symptoms right now. Some of you will asymptomatic, but you might, you know, if you do this for a few minutes, some people might get dizzy and start showing, you know, nystagmus, even though you've got no other symptoms whatsoever. You can confuse this with what? What will you might confuse this with? If you give this test and they start, you think, vertebral artery issue, or the exam, BPPV, right? You're doing the same thing. If you push a patient, and what's the maneuver called when you go like into that position on the plinth? Or pike dicks. That's what you're doing essentially. You're doing a vertebral artery test almost. Very similar. And so you can generate those symptoms in those patients. Watch out. You know, don't mistake one for the other. Okay. It goes, those vertebral arteries follow up, they make it bend right above C1 and go into the brain through this big old hole here. The foramen magnum. Okay? Right up the brain stem. That's the big hole in the occipital bone. Okay? Some people, I just grabbed this just a few minutes ago. You can see this co-eye CAT scan. This person does not have a left vertebral artery. It's gone. So this one here is a vertebral artery. This person does not have one. The carotid here. Back there should be, going through the bone, should be a vertebral artery. Looking at the foramen magnum here, hasn't got one. Some people just born that way, as it were. Some people are very, very, very small ones. There's quite a variety in these arteries between people. Okay, let's mention this. I can post this diagram if you want. You've got to watch out for these vertebral artery dissections. So when you're doing a vertebral artery test, this is one of the things you're testing for. An artery, you know what an artery dissection is? It's where basically the blood gets underneath one of the internal layers of the blood vessel. Another picture. I just grab these two pictures now, but I can post them if you want. But basically, this is the blood flow up here, and you get a little cut or a lesion for one reason or whatever on the inner lining of the blood vessel. So what happens, the blood gets behind it and starts pooling, like in a stream. So you don't get smooth laminar flow, you get a gurgling with blood. So it gets underneath this lump. It's called an arterial dissection. The blood dissects away the wall of the artery. And because you get this turbulence in the blood around this dissection, you start getting clots, of course. Okay? And these are serious things. People have been known to die from these after a chiropractic manipulation. It's a very, very sore topic in the chiropractic community, watching out for VADs, vertebral artery dissections. They're not as uncommon as you think. So really, really be watching out for these in your vertebral artery tests. Yeah, this is what you think about. And I say I can update this slide package if you want. Watch out for your 5Ds. in a patient you suspect might have a vertebral artery dissection. So anytime you're going to do any neck treatment on these people, this can be very, very dangerous. 99% of the time you're fine. But I saw a case a little while ago in Australia where a chiropractic did one of these quick manipulations on a neck, crack it, here's, $500. See you later, the patient died. Because they had a vertebral artery dissection. And they, basically broke it off, we stopped the running brain. So dizziness, fainting, double vision, trouble with speech and swallowing. Those are your 5 Ds. If a patient's presenting with those, be careful. Okay? And then you can have your N's, your nausea, numbness, nystagmus. These are things to look out for in a patient who potentially has a vertebral artery dissection going on. The vertebral arteries are very prone to atherosclerosis too. Atherosclerosis. They clog up quite easily. I can't remember the exact figure now. I think they did routine autopsies on people who have no symptoms whatsoever, and they found that I think it was 40% of them, I can't remember, 40 or 50% of these people who were completely fine had one or at least one of these arteries, carotid or vertebral arteries, closed by 50%. Just in normal everyday life, these arteries get closed in people due to bad diet, etc., etc., etc. Plaque buildup. It's very common to have your internal carotids and your vertebral arteries shutting down, even though you don't know without any symptoms. Okay? Remember, you've got 4 arteries. You've got a lot of redundancy, fortunately, going into the brain for blood. Okay? But if you've only got one vertebral artery and one's clogged up, you're in a mess. So where does this vertebral artery go? These 2 vertebral arteries, once they get into the foramen magnum, into that big hole. So this is out of your anatomy book. Let me find a better picture. We've got lots of pictures here. I kind of flick through them. Here's one I like, probably. It's kind of clear. So your 2 vertebral arteries come up the brainstem and join to form one basilar artery. It runs right at the anterior ventral aspect of the brainstem. The basilar artery, or basal, I think I've heard it pronounced sometimes. Did you cover this at all in A&P? Have you talked about cerebral blood flow at all in any class? No? This is all completely foreign to you? Okay. So we'll go very slowly. So your 2 vertebral arteries come up through the foramen magnum, fuse, join into one basilar. This is the only place really you get one of anything. Everything else is paired, left and right, everything else. But you've only got one basilar artery. Okay. But before they fuse into, they join to make one basilar, you can see them giving off the anterior spinal artery. The anterior spinal artery runs all the way down the front of the spinal cord. They also give off can you see it there? Posterior spinal arteries. A pair of them. You've only got one anterior, it goes down the middle. But you have 2 posterior, a left and right. Now those sometimes come off the vertebral arteries, but sometimes they come off the pica, the posterior inferior cerebellar artery. So, let me find a better picture. So your first 2 major branches coming off the vertebral, these 2 big ones here are the posterior PICA, posterior inferior cerebellar artery. That obviously goes to the back bottom of your cerebellum. Sometimes you'll see the posterior spinal arteries coming off those. Sometimes they'll come off the vertebral arteries themselves. Either way, no big deal. They'll go down either side of the spine, and left and right. And they are going to supply blood with what part of the cord then? if I have a right posterior spinal artery lesion, what would I lose? Remember the territory that these arteries supply. Posterior columns, right? The posterior columns. Posterior columns. We showed you that diagram a while ago about where the blood, you know, when we look at the cord, what blood supplies what parts of the cord. The posterior columns, right? So again now, what do I lose if I lose, I have an occlusion of the right posterior spinal artery at T5. What would I lose?
The proprioception touch pressure.
You're going to lose the fasciculus gracilis tract, aren't you? Exactly, yes. The vibration, all that stuff going up the fasciculus gracilis. If it's higher up, you might have fasciculus cunatus going as well. That proprioceptive pathway is in the back of the cord. The dorsal meniscal system, remember? That proprioceptive system. So, again, two vertebral arteries. Before they form the bacilla, they're going to get off anterior and posterior spinal arteries and the posterior inferior cerebellar artery. Okay? Where have we come across that pica before? Wallenberg syndrome. Wallenberg syndrome. Remember that one? It comes round the rostral medulla. That's the artery, the blue one here, weaving its way around to get to the cerebellum, innervates or supplies this part of the brainstem with blood. That's the one, remember, where you've got ipsilateral pain and temperature loss from the face and your contralateral from the body. Okay? Okay, let's carry on up the basilar artery. So one big fat artery that goes up the front side of the brainstem. It's going to end by bifurcating into a Y. So the bacilla stop. The name of the bacilla ends when it changes its Y shape. And those two branches of the Y are known as the posterior cerebral arteries. Posterior cerebral. So two vertebral join, bacilla splits to make a right and left posterior cerebral artery. But before it splits, it does give off some other branches you should be aware of. So these branches here, let's go through them. So, posterior, the pica comes off the vertebral. Got that one. Then we form the bacilla. The first thing that comes off, after it's named the bacilla, is this one here, the anterior inferior cerebellar artery. As the name suggests, it goes to the front bottom of the cerebellum. Okay? The very top, just before it becomes posterior cerebral, it gives off these two branches. Superior cerebellar arteries. I know a lot of words here that sound the same, but don't confuse cerebellar artery with cerebral artery. So you've got three pairs of cerebellar arteries. Posterior inferior, anterior inferior, and superior cerebellar. Okay? And as the name suggests, they just go to various parts of the cerebellum. They're shown here. You can follow through in the colour where they go, those three pairs of cerebellar arteries. Obviously, therefore, a lesion to any of these arteries is going to cause cerebellar symptoms, isn't it? Obviously. If you clog your vertebral arteries give rise to all of your cerebellar arteries. So if you have problems with the vertebral arteries, you're going to have problems with cerebellum. The ataxic, all those cerebellar issues you can see. Okay? The carotids do not supply the cerebellum. It's the vertebral arteries and the basilar artery, whatever, supply cerebellum. So you can see cerebellar symptoms if you lose the vertebral arteries. Chris? Did you brain dissection? Did you get there?
You could see part of it. Part of it had kind of pulled apart, but you could see part of it.
Okay. The 6th-year PT students now are doing some brain dissections. So some of the DOs who came in who helped you a lot in the PT last year, they're doing some organs. So if you ever want to go in there any time from now to the end of the semester, they're doing a few brain dissections. We're getting out the heart and lungs. We're getting out the spinal cord, I think. Might be looking at the liver and kidneys, all those deep organs they're dissecting right now, and all the joints are dissected. So you can go in there anytime you want, with 6s, without them, whatever, get a key, go down there and look at the heart and lungs. We're trying to pull out the heart with the smokers, nasty things usually. I haven't looked at this one, but if you get a smoker, it's disgusting. It's black, nasty. With some stroke patients we kind of pull out, and you often will see subdural hematomas. Strokes often, depends how big they are, sometimes you can't see them. Sometimes you pull out a hematoma and the brain tissue is just kind of like porridge, mush, it's just atrophy and nothing. And we don't know what we see until we take out those brains. But they're there for you lot to look at anytime you want, from now to the end of the semester. Okay, another another important artery we haven't mentioned that comes off the vestibular artery is this fella here, the internal auditory artery. Sometimes it's called the internal acoustic artery. Sometimes, what's it called here? Internal auditory artery here. It's called here. Sometimes it's called the labyrinth artery. What's it called there? Labyrinth there, yeah. The labyrinth artery. Going to the labyrinth. Labyrinth or internal acoustic. Okay? So where do you think that goes, obviously? The vestibular apparatus. Okay? That internal auditory artery goes out to the cochlear and our semicircumflex and our uterosacral. So this is why, if you give a patient a vertebral artery test and you close one side down and they present with vertebral artery symptoms, it's because you're closing off the vertebral arteries, which in turn supply the internal auditory artery, or acoustic artery, or labyrinth, whatever you're going to call it, which in turn supplies the vestibular apparatus. Okay? And of course cerebellum. So that is why you'll see nausea, nystagmus, etc., if you shut down the vertebral artery in some people, because you're depriving the vestibular apparatus of blood. Okay? Last thing, you also see these little pontine arteries coming off. Lots of little pontine arteries, of course, going to the pons. So this is very important blood to get into the brainstem. Remember, your brainstem is your vegetative functions of the body. You lose this, you're in a mess. Okay. So these two, on the front side of the brainstem, remember, down here, these columns, this is where all our motor fibers are coming down. Remember, the pyramids, medulla, all our cerebral crew. On the front side of the brainstem, we get all our motor fibers coming down to the cortical bulbar tract, the cortical spinal tract, both lateral and anterior, come down the front of the brainstem. So if you get a mass lesion, a stroke, occlusion to the vertebral artery or basilar artery, you often will affect the anterior aspects of your brainstem, the motor pathways, and you end up can get what's known as a locked-in syndrome, where a person basically is cognitively completely intact. There's nothing wrong with the brain whatsoever. You've just wiped out all their motor fibers completely. They cannot twitch a muscle. They're in there, in the brain, perfectly normal. They cannot speak, they cannot move an arm, they can't write, they can't do anything. Sometimes, because the oculomotor nerve is one of the higher ones up in the brainstem, that's spared, so they might be able to blink their eye. close their eyelid, move their eyes left and right. Often they can't move their facial muscles, but they might be able to look left and right using ocular motor nerve or various, higher, and so they'll communicate using their eye movements. This must be the most terrible thing ever to get. I mean, I'd rather be a complete vegetable and not aware of what's going on in the world than be locked into my body and not be able to tell a single person that I'm alive inside of me. They think that person is just a vegetable, but their cognition is completely fine. They've just lost every motor pathway in their body. They can't twitch a muscle, but they're locked in there. And that's what you'll get if you destroy the columns and motor fibers coming down the anterior ventral brainstem due to one of these lesions. Okay. Let's go back to the end of our vertebral artery. Which one should we look at? This one. So remember, the posterior cerebral arteries are the end of our basilar artery. And remember this one, Weber syndrome. Remember what that was caused by? Yeah, posterior cerebral artery stroke. This was going to cause what? Weber syndrome. What was that one about? What's it clogging up here? Motor pathways, right? And ocular motor palsy. Ipsilateral ocular motor palsy. Okay, let's look at where those posterior cerebral arteries go. So this is the end of the bacilla. Posterior arteries. So we basically have three pairs of arteries that supply the cerebrum. Posterior, anterior, and middle. Those are the three big arteries that supply most of the cerebrum. Posterior, medial, and anterior. The posterior cerebral arteries come off the bacilla, which in turn came off the vertebral. The middle and anterior come off our internal carotids, and we'll deal with those in a minute or two. Now let's look at that posterior cerebral artery. Here it is, this one here. It supplies this shaded area here. Around this is the outside of the brain, this chunk here. But if we split the brain in half and look inside of it, you can see this chunk here is supplied by the posterior cerebral artery. Back of the head, the occipital lobe kind of thing, most of it. There's an important artery that comes off there, clinically. It's off the screen here. The calcarine artery. The calcarine artery. You can see it right there on this screen. It's off the top of that one there. Here it is here. It's the inside of the brain, sliced in half. There's my calcarine artery coming off the posterior cerebral artery. I'm going to give you a stroke in your right, just the right side here, the right calcarine artery. What symptoms did you present with? A complete stroke in your right calcarine artery. What would you see in a patient? This could be an exam question. So I shouldn't really review it, should I? What would I see?
Left homonymous hemianopsia.
Left homonymous hemianopsia. The left visual field, remember, of both eyes is gone. Right cortex, remember, the calcarine artery supplies the occipital cortex of both, left and right on both sides. So I lose my right one. Therefore I lose the left visual field on both sides. Because both eyes are sending information from the left hand side to the right brain. Simple. Right? Okay. Carotids. Okay, so the carotids supply more blood than the vertebral arteries. So the vertebral arteries, again, review. Cerebellar arteries come off the internal carotids. Sorry, vertebral arteries, the basilar, and eventually the posterior cerebral. Okay, but the rest, most of the dome of the head, the brain, comes off our internal carotids. They're bigger arteries. Okay. The right, so these are the internal carotids. The internal carotids supply the brain with blood. But they come off in turn the common carotids. Common carotids come off the right one, which is the right common carotid here, comes off the right brachiocephalic trunk here. Okay? So your right common carotid comes off the right brachiocephalic trunk. We don't have a left brachiocephalic trunk, do we, remember? From your, whatever. Maybe you didn't. But you don't have one. So your left common carotid comes off the aortic arch itself, right here. Okay? That's the only difference between these two. Okay, so they now travel up the front of the spine, and they'll split. The common carotids will now split, will bifurcate into a Y-shaped pattern round about the angle of the mandible, which is about, this corner of your jawbone there. They roughly split about there into the internal carotid and the external carotid. Okay? The internal carotid and the external carotid. Where they split, of course, we find our carotid sinus. We all know what happens to carotid sinus, don't we? We all know what receptors are there. We all know what nerve supplies those receptors that sample the O2 of the blood, the CO2. What nerve goes there? What cranial nerve? Oropharyngeal. That's what, sensing the blood there. Okay? The external carotids do not supply the brain with blood. The internal carotids do. But there are some clinical tips relevant, I think, to the external carotids. So before we get to the internal carotids, I'll mention a few words about before I get to the internal, I'll mention a few words about the external. Internal carotids go to the brain. External do not. External carotids go up the side of the head. And there's some clinical relevance to some of this, particularly one artery in a minute. So the external carotids supply the face and neck, the outside of the head, essentially. Okay? There's some important arteries given off the external carotids. The superior thyroid artery. This goes to the larynx, voice box area. Goes to the thyroid gland. So there can be issues here, obviously, in the larynx if you lose blood in this. The lingual artery comes off the external carotid. Where do you think that goes? Lingual, tongue, saliva glands. Again, not the brain, but, useful to know. And another big one, which is useful for first aid, or, to watch out for, is your facial artery. The facial artery winds its way around the mandible to that little notch. You should be able to, if you find the angle of your mandible, come forward about, half an inch, you feel a divot in your jawbone, right? A little groove. There's an artery there. Can you feel your pulse right there on that divot in the side of your mandible? Yeah, easy. I find it's a very easy place to get pulse on most people. You found that? Little pulse, right that little divot in the edge of the bottom of the mandible. That's your facial artery. That's your facial artery weaving around on the side of the face. goes up to the cheek and nose eventually. Good pressure point. Somebody's got a big laceration in their cheek or their nose and it's bleeding like crazy. You press on there, you'll cut the blood off to the side of the face. Useful place to be able to A, get a pulse, and B, pressure point for stopping the blood, the bleeding. Okay? Okay, so those arteries come off the external carotid. The external carotid ends, its name ends anyway, by splitting into two again. All these things end and they become other names. And then it splits into the superficial temporal artery. Let me put a better picture somewhere here. Here we go. The superficial temporal artery goes straight up. Okay? And the maxillary artery, where's it not even labelled there? Is this one here. What is written on there? Maxillary artery. You look at book one. You can see it here. Not as big though. Maxillary artery going here, and the superficial temporal artery coming up here. You should be able to take your superficial temporal pulse. Right? Have you taught to do that one at all? In any class now? Just in front of the ear hole. In front of the ear, right in front of the external auditory meatus. So here's the ear hole, here, there's the auditory meatus there. Right in front of the ear, you should be able to find a superficial temporal artery pulse. Yeah? Got it. Okay? Supplies the side of the, side of the scalp, right? I've actually seen a surgery in England where some bloke had a middle cerebral artery stroke, and it wasn't a stroke, it was a occlusion of the middle cerebral artery. It comes out to the side of the head here. It was clogged on one side. So what they did, they cut a hole in his scalp, took a chunk of his skull out, got a superficial temporal artery, and got a graft and let it into his brain from the outside, and put his bone back on with a hole in it. So now the side of his brain over here, normally supplied by the middle cerebral artery coming this way, the blood from it came up the side of his head into the superficial temporal artery, into the outside of his brain from the outside rather than coming from the inside. By hooking up the superficial temporal artery into the edge of his brain that way. Kind of cool surgery. The maxillary artery gives off one very important artery. That's very important clinically. The middle meningeal artery. So what are we talking about this? The middle meningeal artery. Very important clinically. The middle meningeal artery comes off the maxillary artery. And this artery, as you probably know, supplies the outside of the skull. Outside of the duometer. So when you look at a skull, Chris has got one, you look at the calvaire, the skull cap, look on the inside of it, you'll see grooves in it. Like a little stream pathways, blood vessel pathways, inside, on the inside of that big skull cap. And that's the middle meningeal artery, and veins have made divots or grooves in that bone. Okay? So, this is your walk and die patients, obviously, right? You've heard of the walk and die patients who come in. So, very commonly, patient has a fall, car accident, they have bone splinters come off the brain, off the skull. And you can see here, they just snip one of these, lacerate one of these middle meningeal arteries. And so blood starts to pool on top between the duometer and the bone. Okay? And that would be known as what type of hematoma? Epidural hematoma. An epidural hematoma. Blood pools over a few hours, and the patient initially presents with no symptoms. This is the lady a couple of years ago, was it Natasha Richardson, who died in Colorado, ski accident.
My dad actually was a volunteer firefighter, and he just responded to an accident, and this guy hit his head really hard and a huge bump, and he refused medical attention, and he died that night.
Exactly.
Yeah, because he wouldn't go in.
He wouldn't go in.
No,
Fine.
he's like, I'm fine.
Yeah. Bad headache, but what big deal? But what's happened, he's ruptured one of those middle meningeal arches. And he'll go to the hospital, neurological signs, fine, yeah. He's going to walk and die or talk and die patients. They come in, yeah, I'm fine, thanks, got a bit of headache, okay, go home, we'll see it, if it gets worse. 2 hours later, he's dead. Because this blood, of course, is pulled up here, and it gradually presses on the brain, and it presses down. Gravity is going to bring it down and press on the most important part, which is the brainstem. Pulls down his brainstem, pushes on the person's brainstem, and within an hour, or 2 hours, or 3 hours, or 4 hours, the person just is dead. This is what happened to Natasha Richardson in Colorado. She had a minor fall, whatever it was. They took her an ambulance, didn't they? And she was not discharged, but they didn't recognize this. And all of a sudden they go, wow, blah, blah, and she gets in a helicopter or whatever, it's too late, she's dead. This is more common than you think, unfortunately. You can bang your head and you can get an epidural hematoma and whatever. So we'll talk about epidural hematoma later. But this is a middle meningeal artery, come off the external carotids. The internal carotids. So they come up here. They come up. These are internal carotids cut off here. They get into the skull through these two little holes. Foramen lacerum. 2 little holes there in the sphenoid bone that allow the internal carotids to get into the brain. They don't come up the foramen magnum like the vertebral arteries do. Okay? On their way, before they actually get right into the skull here, they'll give off the ophthalmic artery. Where is that? Hang on, let me stick around here. Where the heck is my ophthalmic artery? Here it is, showing here. Number 2 there. So before they get right into the foramen lacerum, they're going to give off the ophthalmic artery. 2 of them, obviously, right and left. Everything's 2, right and left, apart from that bacilla. So we're going to have 2 ophthalmic arteries leading towards the eye. Okay? I have a stroke, I have an occlusion in my left ophthalmic artery. A bit of plaque has come off my heart. It's gone off these huge internal carotids. It floats down and gets sucked into my left, should I say, ophthalmic artery. Closes off completely. What symptoms the patient present? Left eye anopsia. Yes? Fair enough? Whole left eye is gone. Both retinal fields, both temporal fields are gone. Left eye anopsia. Because you've got this ophthalmic stroke in the left one in this case. Okay, so those arteries, those internal carotid arteries branch into 2. Okay, they give rise to the, so it's not a very good diagram. You see these 2 pipes, what are here, they're coming out towards you. They're going up into the screen, and they give rise to these 2 major arteries. The middle cerebral artery and the anterior cerebral artery. Middle is larger. The middle cerebral artery supplies more of the work, more area of the brain. Yes, after they've come through the foramen lacerum into this little junction here, which we call, have you ever heard of the circle of Willis? The circle of Willis, we'll get back to that in a minute, but they come into this sort of mess here, and they immediately give rise to the middle cerebral arteries and the anterior cerebral arteries. One goes out laterally and one goes forwards, essentially. Let's look at the middle cerebral artery. The anterior cerebral artery first. This goes through the longitudinal fissure like this. It goes up forwards and supplies the interior of the brain, the inside this longitudinal fissure. Here it is like this. Okay, it supplies the medial aspects of both hemispheres, the insides of both hemispheres. But it overlaps a bit onto the top. So let's look at this diagram perhaps. So you can see this is a slice of the brain on the bottom here, cut in half. So I've taken off the left hemisphere here. I'm looking at the inside of the right hemisphere. You can see all this inside of the brain here is supplied by the anterior cerebral. If you look at the outside of the brain, you can see it overlaps, it comes out of the longitudinal fissure and overlaps slightly onto the hemispheres like this. That makes sense? So, which part of the motor cortex is it supplying? Which part of the body is it supplying? Remember as somatopical organization of the motor cortex and the sensory cortex? What do they look like?
Feet, legs.
Feet and legs are where? In the crack, aren't they? Overhand, the bloke's hanging upside down over the head like this. Hands, face, upper body is down on this side, isn't it? Inside the crack is our arms and, our legs. Okay? So, you can see this part, this anterior cerebral artery supplying this part of the brain, right? And this part. So what part of the, if you have a stroke in your anterior cerebral artery, what are you going to lose? The lower extremities, right? Lower extremity, left or right, depending which side it is, or both, whatever, if you get a massive one. Here's another good diagram, this one down here on the bottom left. This is your anterior cerebral coming out, up to the middle of the brain and overlapping onto the top a little bit. Whereas the middle cerebral artery comes out the side here and supplies, it comes out the lateral sulcus, so here's your middle cerebral artery coming out and supplying this huge chunk of the side of the heads here. Okay, that's going to have a bigger area of territory than the anterior cerebral. So you've got a middle cerebral artery stroke on the right hand side. What are you going to see? Motor cortex wise. And face issues. Okay? Particularly upper extremity. Why would you not see as prominent symptoms in the face as you would in the upper extremity?
Face has such a big area of the motor cortex.
No, the face has got a huge chunk, correct, Nick? A huge chunk of the face on the side of the head here, isn't there? And the upper extremity. But I've got a stroke and I've killed that middle cerebral artery on the right hand side completely, let's pretend. Why would I see more symptoms in my left arm, yes, than my left face, lips, tongue, whatever, eyes, balls?
The upper part of the face is bilateral.
And?
Contralateral.
What else? What about the oculomotor nerve? What about abducens nerve? What about trochlear nerve? What about hypoglossal, not hypoglossal? What about glossopharyngeal? What are they? Do they have bilateral or contralateral supply? Bilateral, don't they? Remember? The cranial nerve nuclei have a bilateral supply to most of them. Except for what? Facial and half the facial, remember as Nick said, and hypoglossal. Those are only contralateral supply. Half the face and the tongue. So that is why a stroke in the right hemisphere is not going to be drastically affect the left cranial nerves as it does my left spinal nerves. Make sense? Because my left hemisphere also sends a signal to my left cranial nerves. Make sense? Alright, we'll come back to this and go over these again next class. Oh, we're finishing. Oh, whatever. We've had enough, haven't you?